Thank you all for coming. So this is our first symposium of the meeting. It's an unopposed symposium called A Case Study on Many Views on Value, Aortic Valve Replacement. The only conflict of interest, I wanted to declare that some of the images I've shown are a TAVR decision aid that I developed in collaboration with the American College of Cardiology. Diving in just a little bit, we wanted the theme this year of many views on value. We wanted to have a symposium where we brought together many views around some procedure and then talk about it in a little more depth and get into the details. And we thought TAVR is a popular thing. There's a lot of recent data. We thought it'd be a good example of something that could highlight some of the challenges of achieving value in healthcare with multiple views. So a little bit about what TAVR is. For years, if you had a tight aortic valve, you could get it replaced with open heart surgery. That's the picture on the right here. And they would put this mechanical valve in there and you could get your valve fixed. Recently, the last 10 or 15 years, they've developed a way to put a valve in the heart without having to open the chest. Basically, it's sort of the same way a cardiac catheterization is done, where you kind of go in through the leg, and then you can go and put a valve in. It's a porcine or pig valve that's all scrunched down, and then they go in and they put the catheter where the aortic valve is, and then they blow it up, and you can put the valve in that way. It's much less invasive because obviously having your chest cracked is a big deal. So this is what TAVR is. It stands for Transcutaneous Aortic Valve or Transluminal Aortic Valve Replacement. My father's been really excited taking us to concerts recently, and we had tickets to see the Stones in Denver in March, and it got canceled because Mick Jagger had to go have major heart surgery. It turns out he had a tight aortic valve. He got the TAVR procedure. We saw him again in, I guess it was August, and he danced for 4 hours on stage, made me feel like I need to go exercise more. Despite what they did in the past, I guess he runs like 6 miles a day and eats really healthy. But this is the kind of person that this valve is for. He didn't have to have open, had he had open heart surgery, I wouldn't have gotten to see him this summer. Because he had a TAVR, I got to see him. So this is the kind of decision here. So there's a couple big decisions. There's 2 populations eligible for TAVR. The first big study was people who were too sick to have surgery. The surgeon said, this person's too sick, I'm not gonna do open heart surgery. And so these were really sick, 80 plus, I'm a geriatrician, patients in my clinic, 80 plus people with dementia, and they have a tight aortic valve. And I remember one of the interventional cardiologists saying, I've never had patients this sick on my table when I'm putting TAVRs in them. But the trial showed a pretty large absolute risk reduction in mortality for people who aren't eligible for surgery. Then the other decision is, which is now becoming more common, is people who could have surgery, people who are less risky. And the first trial showed that they were kind of equivalent, and then more recently now it looks like TAVR might even be better than the surgical valve for people who are younger, people with like a bicuspid valve or something, a congenital aortic valve that's tight. But they have a different decision now because we don't know how long these valves last. And we know the surgical valve, you put that metal valve in and you take anticoagulation, we know it'll last 20 or 30 years. So if you're gonna live that long, you still have a decision. Should I do surgery or should I do this other valve? So there's still some trade-offs. But those are a couple of the populations that are being considered for this sort of surgery. And then so back to the theme. If we think of value as benefits over costs, and it's really about whose benefits are we talking about, who benefits at different levels, and whose costs are we talking about. So our panel here is people to talk about benefits and costs of this procedure, this TAVR procedure, from different lenses and different perspectives. We have just a wonderful panel of people. Susan Strong, to give the patient perspective, she'll speak next. And Ty Gluckman is a cardiologist here in Providence in Oregon, who does a lot of work that I know through the American College of Cardiology. He's gonna talk about the clinician's perspective. Lawrence Freudenstahl, who is a chief financial officer at Oregon Health Sciences University, and then Judy Zerzan, an old friend who used to be in my division in Colorado, and then was a Colorado chief medical officer at Colorado Medicaid, and then moved and is now chief medical officer at the Washington State Healthcare Authority. So we just have a great group. And then at the end, Valerie Reyno will bring it together and talk about a researcher's perspective on value. And then at the end, we'll leave some time for questions. So that's how this symposium will go. So with that, I'll turn it over to Susan.
Good morning, everybody. Oops. Kudos for having the patient perspective here. I appreciate that. I'm the Director of Patient Engagement for Heart Valve Voice. We're based in Washington, D.C., and we're the only patient-led organization representing patients with specifically heart valve disease. And I've been a practicing patient, actually, for 36 years. In 1983, I was diagnosed with Hodgkin's lymphoma. If I had been diagnosed a decade before, it's very likely I wouldn't be here today. And in about 2012, I discovered late effects from the high-dose radiation, mantle radiation that was done in the 70s, 80s, and 90s to treat Hodgkin's lymphoma successfully. And I learned that I had developed severe aortic stenosis. And the first option that was given to me was open heart surgery. At that time, only the severe risk was done, and then the FDA had just opened it up to high risk, and my cardiologist didn't think I would qualify, but I went to University of Denver Hospital, and their TAVR program had been part of clinical trials, and found out that I was eligible to have TAVR, and I felt like I had won the lottery, because an open heart procedure on a radiated chest is very high risk. It's very dangerous, but unfortunately not every physician across the country is aware of that, because there's not a lot of Hodgkin's patients around. So people were getting different information about it. And then a couple of years ago, I found out I had HER2-positive breast cancer, again, as a late effect from the radiation. But today, I'm grateful and really happy to be here and happy to be representing patients and a patient advocate. I'm actually quite busy doing that. I created this little word cloud of different words, different ideas, different decisions that patients have to think about when they're deciding between an open heart procedure and a TAVR procedure. And it's a very complicated decision. It's not an easy choice. Things that patients have to think about: mechanical valve versus a tissue valve. You can actually get a mechanical or a tissue valve surgically, or in TAVR, you can only get a tissue valve. Tissue valves do tend to wear out. I had a TAVR at the age of 49, which was very young. So the future is a little unknown for me. I'm hoping to be able to have a valve-in-valve TAVR replacement at some point in the future. Next month will actually be 5 years that I've had my TAVR in, and everything's going well, so would love to be able to have that valve for a long time. People having mechanical valves have to consider a lifetime of taking anticoagulation medication, and for younger patients who are active, that's concerning. Sometimes some of the other medications, older medications, impacted diet. So there are a lot of things that patients have to consider and that impact their lives. The patient experience is so much more than a survey that happens in an institution while the patient is there. The patient experience is a lifetime leading up to that time, and then a lifetime after a procedure. My experience was different because of my history of Hodgkin's, and that really made a difference and an impact on the decisions that I made. Very different probably than someone my age who hadn't had that history of radiation. Younger patients especially are thinking about recovery. I was a full-time middle school teacher at the time that I had my valve replacement. And when I first thought I was going to have open heart surgery, I was really worried about potentially missing 3 months of work and having to do substitute plans. And I didn't have a date when my surgery was going to take place. And so created a lot of anxiety about it. And even then, when I found out I was going to have TAVR, I was waiting for my valve to get FDA approval. And so it was over a year from when I was diagnosed to when I had the TAVR. Quality of life is an issue. TAVR has definitely been shown to give a high quality of life in the first year after. The results after that, comparing it to surgery, are a little indefinite. We just don't know yet. Patients are worried about the risks of stroke, having a pacemaker. On patient sites, I hear about pump head, of patients having cognitive issues after being on the heart-lung replacement, or pump, whatever that's called, during surgery. Invasive. Even the scar from an open heart surgery impacts patients. They think about it. It's a concern. For me, I'd had an exploratory laparotomy, so I had a very large scar before, and emotionally I felt like, great, they're just gonna, cut me open like a fish all the way up to the top. So, there's emotional aspects to things that you might not think about in research. And then, of course, pain, recovery, that sort of thing. Low-risk patients now who've just gotten the approval tend to be younger, healthier, have fewer comorbidities. The idea of aortic stenosis a lot of times is the only issue they're looking at, rather than a much sicker patient who has multiple comorbidities. I talked to patients, and I felt this way myself, who, because the aortic stenosis is the only issue, you feel immediately much better, able to breathe, able to walk, able to hike. So the difference between open heart and TAVR in that circumstance is very different. Younger patients place a high quality of and value on a quality of life now and in the future. And then we're having to weigh like the present benefits versus the future unknowns. I'm choosing to trust that the valve-in-valve will work for me, maybe even multiple valve-in-valves, or maybe science will just change, and there'll be a completely new way to take care of my valve. With my history, I don't know how long I'll live. There's real-life conflicts. As the Director of Patient Engagement at Heart Valve Voice, I got a letter last week from a gentleman who his insurance had approved him to have an open heart procedure, and then he decided, the FDA approved low risk, he wanted to have TAVR, had it all set to go, and then had a date for October 25th, just later this week, I think, and his insurance company denied it, said it wasn't medically necessary, even though he was already approved for surgery. He was quite disappointed and upset. I connected him with the Patient Advocate Foundation, and I just got an email from him last night that he was unsuccessful with his insurance. He's afraid to wait to get his valve fixed because aortic stenosis is fatal. I mean, it's worse than cancer if it's untreated. And so he's decided to have open heart surgery. He's 67. It's not what he wanted to do, but he kind of felt like the choice was forced upon him. So the importance of shared decision-making, especially in a situation like this, the patient values really are key to the treatment choice. There are trade-offs in this particular treatment choice, and patients have to decide what is the most important thing to them. Patients who really want to know what's been done, what's been studied, they want to minimize unknowns, they may prefer an open heart procedure. Other patients, for me, I was very afraid that an open heart procedure for me, that I might not survive or that it would impact my quality of life for the future. So I would rather have the trade-off of good quality of life now and kind of an unknown for the future. But I was living with that anyway. The concern that I see in talking with many, many patients is that patients are not being presented with standardized information and options. It really kind of depends on where you are and who you talk to, the advice that you get. My concern is if patients don't fully understand the trade-offs, that it's really not even possible to have true shared decision-making. This is a really great painting that a TAVR patient made. I have an online support group on Facebook for TAVR patients, and she did a painting, and on the side with all of the red was how she was feeling. She is she's a Hodgkin's patient as well, and was told that she would not survive an open heart surgery. So that was how she was feeling before, very dark, very afraid. She had TAVR, and you can see the heartbeat gets stronger and the colors get brighter, And she's talking now about how she's feeling great and doing hobbies and really enjoying her life again, because she had a very difficult time even walking and breathing prior to the TAVR procedure. So it's a work in progress. I see hearts everywhere I go. I took this picture. We were remodeling a house and I looked down and saw that. So it's a work in progress. I appreciate you allowing me to be part of the discussion, and I'm available if you have any questions after, and of course we'll have the panel. So thank you very much.
It's hard to do justice in following that. Thank you very much. My name is Ty Gluckman. I am a non-invasive, non-interventional cardiologist just across the river here at St. Vincent Medical Center. And I serve as medical director of a Center for Cardiovascular Analytics Research and Data Science, hopefully bringing an analytical side to the work that we do. And I do want to echo the point that was just brought up is I wish there was a way to standardize communication, education, awareness about the conditions that we're dealing with, but sometimes it very much does depend upon who you talk to. It shouldn't, but it often does. I apologize for not including a disclosure slide, but I have no disclosures. And the only other thing that I would say is for the American College of Cardiology nationally, one of my hats that I wear is to identify gaps in care and come up with solutions to close those gaps, which is, I dare say, easier said than done. So I was asked to provide the perspective of a clinician, the clinician voice in all of this. And I want to just give you a little bit of perspective about how prevalent this condition is, because it informs, sometimes if we talk about very rare conditions, it's not that shared decision-making isn't important, but you may be dealing with a very narrow slice of people involved. So believe it or not, there's not a lot of recent natural history data on this condition overall, but this is data from Iceland that looked at almost 700 individuals in Iceland between the ages of late 60s to mid 90s. And I think 2 points to bring up on this overall is that A, the prevalence of aortic stenosis is greater as we age. It is just more likely to have aortic stenosis in the septuagenarians and octogenarians in general. And B, the prevalence of the condition is expected to grow because we're keeping people alive longer and people are living to be 80 and 90. And we just had someone recently who was 104 who had TAVR done. And that sounds perhaps a little bit mysterious, maybe crazy might come to mind, but I dare say I have some 90-year-olds who look like they're 70 and some 70-year-olds who look like they're 90, so chronological age is not necessarily the biggest driver in terms of our decision-making. But look here, though, in people who are less than 70, the prevalence is 0.9%. In people between the ages of 70 and 79, it's 2.4%. But we're exceeding 7% of people greater than or equal to 80 years of age with severe aortic stenosis, so a pretty common condition. And this is from the Census Bureau. Not something I frequently dive into and look at, but at least highlights that looking out to 2050, the individuals in their 80s and arguably in some of their 70s are expected to grow as a percentage of the pie of those individuals 65 and greater in age. So this may look blurry, and actually I look back at it, it's from 1968, and I highlight that only to say it is actually this blurry when it was published in 1968. But it highlights the path of somebody with aortic stenosis. It's essentially a plumbing problem, and I don't mean that in a pejorative way at all, but it's a progressive fixed narrowing of the valve that eventually creates a compromise in blood being able to be ejected out by the heart. Heart's a very selfish organ, I admit to that as a cardiologist, and it steals its own blood supply first, so if it doesn't get enough blood out of the heart, it doesn't give itself enough blood, and as a result, lightheadedness, shortness of breath, chest discomfort can be common symptoms. And it just highlights the fact that once people develop symptoms, there's a pretty abrupt drop-off in terms of how people do. And blown up on the right-hand side is if you present with heart failure, your average survival is 2 years. If you have syncope or loss of consciousness, your average survival is 3 years. And if you have angina or chest discomfort related to an imbalance of demand and supply of blood flow, your average survival is 5 years. And it was pointed out, these are prognoses that are comparable to or worse than a lot of malignancies that we deal with overall. Shown on the left-hand slide is a slide that was taken from 1982 that said, going back now, we're approaching 40 years ago, that in the natural history of people who had severe symptomatic aortic stenosis, by doing aortic valve replacement, AVR, you could keep about 85% of people alive out to 5 years, whereas medical treatment, which was essentially not much could be done, you'd have roughly about 20% of people surviving out to 3 years. And this is reflective on the right-hand side that data from the Society of Thoracic Surgeons database, there were in 2013, 2014, and 2015, roughly 30,000 surgical aortic valve replacements performed annually. And at the bottom, you can just see the breakdown of the different types of conditions or categories of risk for these. We generally deem that if your operative or 30-day mortality was greater than or equal to 8%, that was high risk, 4 to 8% was intermediate risk, less than 4% was low risk. And as you can see, the vast majority, 8 out of 10 people were deemed low risk, and that's the group that was just given approval by the FDA as a cohort of individuals for TAVR overall. Dan already covered this, but I just want to give another picture or pictorial demonstration of what all of our valves look like, or most of all of our valves, hopefully in the audience, look like in terms of the open and closed state on the left-hand side in the upper portion. And then the stenosis is due to often a calcification and thickening of the valve overall. And TAVR affords, in most cases, through the leg, in some cases, alternate access through the carotid artery or the subclavian artery, the ability to place a catheter, cross that valve, inflate a valve that is crimped on a small metal cage that looks like the stents that we put in people's coronary arteries, but larger. You then deploy the valve, deflate the balloon, withdraw it, and in some cases, when things go well, we see from start to stop the procedure times anywhere from 35 to 40 minutes to get the valve done and replaced. We have now seen sites for us across the street. We do upwards of 400 of these cases a year. We're expecting to significantly increase that, sort of robbing Peter to pay Paul, taking those people who are surgery patients, going to the transcatheter approach overall, or TAVR. But I'd say about 90% of our patients go home the next morning after their procedure. We are seeing sites in the United States where they're even doing same-day discharge. You go home that evening after your procedure, after your valve is replaced. This sounds crazy, and I would have said it was crazy years ago, but it really is quite common these days. This is data that was published out of actually the Finnish registry. It was just published a few weeks ago in JAMA Network Open. And it just highlights in that low-risk group of about 2,800 people from their national registry in Finland what the mortality or survival was out to 3 years for both surgical and transcatheter aortic valve replacement, and they're largely the same. So to a large degree, equal survival. And the question is then, how do you inform decisions from a clinician perspective overall? And I've highlighted, I think, a lot, but it's not a comprehensive list of factors that may favor TAVR. Obviously, if people can't get surgical aortic valve replacement, we talked about that already, it avoids the need for cardiopulmonary bypass, the heart-lung machine. It avoids the need, in most cases, for general anesthesia, shorter procedure time, shorter hospital stays, and then, as we heard before, shorter recovery time. In some cases, people are getting other, I'm going to use the word stuff, generically done in the operating room above and beyond aortic valve replacement. They may need a second valve intervened on. They may need concomitant coronary artery bypass graft surgery, although even that's being tackled by different ways. They may have such a small annulus or hole where the valve sits, or a very big one where they don't actually even make valves that accommodate those sizes. You may have an infection on the heart valve that may preclude it, etc. And then finally, TAVR itself does not have its own, is not without its own limitations. So-called perivalvular leak, where when you deploy the valve, if there's a leak around the valve edge, those individuals prognostically do worse. The conduction system of the heart sits just adjacent to the aortic valve, so if you deploy the valve in just the wrong way, not the right way, or even done correctly, there's a chance of disrupting the conduction system, and in vulnerable people, it can actually lead to heart block necessitating a pacemaker. And we've essentially had these valves in this country for under 10 years. Internationally, particularly in Germany and Vancouver, British Columbia, we're now into the 15-plus year time frame, but we don't have 20, 30, 40-year data on these valves. And so how durable will they be? And so the option is being offered up of doing so-called valve in valve, where you've deployed one valve, you just put another valve within that valve, or valve in valve in valve, you put your third valve within your second valve within your first valve. People are beginning to think, and technology is affording us potentially options like that down the road. I'm just going to end on this slide as the good, the bad, and the ugly. So this is data from the STS and TVT, Transvalvular Therapeutics Registry. This is the world's largest registry for TAVR cases that exist today. And this is data going back now published in 2017 by an international expert, Suzanne Arnold in Kansas City on this. And the national coverage determination by CMS requires people to get baseline 30-day and 1-year quality of life assessments overall. So this is part of the good, bad, and ugly. One of the key measures is called the Kansas City Cardiomyopathy Questionnaire. And as you can see on the far left that's seen there, people abruptly, and I'm talking about within even less than a month, will feel much better. Their quality of life will go up substantially. This is only looking at intermediate and even a small snapshot of intermediate and mostly high-risk individuals, just so you know. But TAVR is associated with substantial improvement in health status at 30 days and 1 year, and that's obvious from this graph. But only 22% of patients had health status assessed, who had their health status assessed at 30 days, actually had it reassessed at 1 year. So this is sort of the bad, this is the shame on us moment, because CMS is telling us in order to get paid, you're required to reassess functional status at 1 year, and only about 1 out of 5 people have that done. And to be fair, this is not easy to do. People move, they don't answer their phones. How do you collect this data when they may not be coming back overall? But the ugly in this is only 62% of patients either had a significant improvement in functional status or were alive at 1 year. So in the bellwether of success, I'd like to think that if 4 out of 10 people aren't either alive or functionally improved at 1 year, admittedly, this is high-risk data, then we're not perhaps selecting the right patients to get this procedure. And only time will tell, as we have this with the intermediate and lower-risk patients, if there are people, some of which who have clear unequivocal improvement and some that do not, how do we better select patients so we're not offering invasive, expensive therapies to people who don't derive the benefit and consolidating that offering to those who do? And I didn't steal Susan's picture, but I have my own. I didn't take this picture. I found it on the internet. I'll be full disclosure. But finding hearts in nature is pretty often common. So thanks so much for the opportunity.
Thank you. Good morning. I think it still is. Those are great presentations, and hopefully I can add another perspective. I'm the Chief Financial Officer of Oregon Health and Science University, which is the public health sciences university and academic health center here in Oregon on the hill diagonally across the river from here. When we think about value, we have one thing we turn to a lot is our mandate. We were created by the people of Oregon and the state legislature, and they laid out in law very clearly what we're supposed to do, which is education, research in healthcare and biomedical sciences, provision of inpatient and outpatient care of all types, outreach throughout the state, being a statewide resource, and then continuing to provide healthcare to the underserved in Oregon, which we've done since 1887. So in one way of looking at this, when we think of value, we think about all of those missions, and the TAVR example hits on many of them. Believe it or not, you're looking at me and thinking, what a young man. I have been a chief financial officer this week of either a teaching hospital or a university that owns a teaching hospital for 32 years, starting in 1987 at the University of Chicago. And what's really interesting is how many things are the same and what is different over 32 years. So 32 years ago, I was the CFO of about a 600-bed hospital, and today I'm a CFO of about a 600-bed hospital. We ran it at 85% occupancy then. We run ours overall at 85% occupancy today. One thing that's dramatically different is that our care on a sort of cost-weighted basis was 85% inpatient, 15% outpatient then, and today it's 50-50, and it moves about a percentage point a year towards the outpatient side, and that's not really just clinic visits, that's very complicated procedures, as mentioned, done on the outpatient side. So as a result of that, the scale, measured in what we call adjusted occupied beds, has gone up really considerably, almost not quite doubled, but coming close to that over that time period. And every budget number has an extra zero on it. We had a $200 million budget 32 years ago. We have a $2 billion budget now. And concomitantly, healthcare as a percentage of GDP was a completely unsustainable 8% in 1987 and is 18% today. As is well known, if you take the GDP and multiply by that 8% and divide by the people, we're spending about $10,500 a person a year in the United States. That 50% of the population uses about 5% of that money, and 5% of the population uses about 50% of the money, or about over $100,000 a person. And even when you get into a university teaching hospital, you see that same concentration goes down. So at OHSU, we did this chart. We see about 1 million visits and admissions a year at OHSU Hospital. Those are delivered to about 200,000 individual patients, and 2.5% of those patients, or about 5,000 out of the 200,000, use nearly 50% of our resources. And the same is true at the University of Chicago and most other teaching hospitals in the United States. So what drives this concentration? I studied economics many years ago, 40 years ago, in fact, at the University of Chicago, a noted place for that dismal science. And the first thing they taught us was something called declining marginal rates of substitution. Years ago, it used to be called declining marginal utility. Right? The more you have of a good, the less one values each individual additional increment. So if you have no pizza at all, you value the first slice of pizza a lot. By the time you've eaten 7 slices of pizza, your valuation of the 8th piece is much less, and you want a beer instead. Okay? This is a well-observed microeconomic fact. Conversely, the less you have of a good, the more one values each increment. One of my professors at the University of Chicago, again about 40 years ago, Sherwin Rosen, was one of the first people to apply this to the good, not of pizza, but of life. Okay? And published an article valuing health risk. In May of 1981, I was taking a course on labor economics, and he was sort of reading this paper to us. It was fascinating to me. You can read the whole paper, but there are a lot of math. He comes to the conclusion, therefore, remember this is from an economist's point of view, maximizing the value of life saved isn't necessarily the same as maximizing the number of lives saved. Lives at greater risk, and he notes in addition, but I won't go into this part, of greater wealth, weigh more heavily. In other words, when you have a lot of life left, right? You're 30 years old, you have no conditions whatsoever, you think you're going to live forever, what you might do to value another year of life might be relatively small, right? But you're told when you're 30 years old that you have a very challenging diagnosis. Suddenly your valuation of another year, another 10 years, another 20 years of life is very, very high, right? That's just a natural outcome of declining marginal utility and is well observed, right? And thus, he wrote 40 years ago, the preference for inexpensive, expensive, crisis-oriented medical procedures rather than cheap, cost-effective preventive measures affecting smaller risks can be rational. Rational in the economist sense, right? Which starts by taking a lot of value, just taking as given the values of the consumer, of the individual, right? And then expressing whether or not they're making well-ordered decisions based upon that. I thought this was fascinating when I was 20 years old, and I've turned out now, when I'm nearly 60, to have spent my entire life basically working around this proposition in academic medicine. So then what are the values of technologies like TAVR to an academic health center with a large health system like OHSU? Well, they have addressed many of those points of view. To the extent they are less invasive, they allow shorter stays and more outpatient care and greater growth per bed. All right? Growth is the engine of our business. Right? Without growth, it's very hard to maintain a healthcare system going forward. The reason we have 600 beds is that they're limited sometimes by law, often by just geography and physicality. And all of the growth has been by leveraging that, going from 15% outpatient to 50% outpatient. So technologies like TAVR on lower risk patients help us continue that growth. Equally importantly, they provide new options for patients at the greatest risk. And one reason healthcare grows, both in individual entities and within the United States of America, is that we can slowly, incrementally, but in real ways, provide more and more options to patients at the greater risk, and those are rightfully valued highly by those patients. Okay. Third is they are part of our research mission, that is to say, to develop and provide studies of new technologies, whether that's something OHSU might have created. Some of the first heart valves were created at OHSU, or just doing clinical trials to see how effective they are. And then finally, because we provide the most advanced and complex care as an academic health center, we are constantly looking to push the state of the art. So for all of those reasons, technologies like TAVR tend to be highly valued by an academic health center. Thanks.
Good morning, everyone. And I did not put a slide saying who I am. So I'm Judy Zerzan. I'm the Chief Medical Officer of the Washington State Healthcare Authority. And this is who we are. We are Washington State's largest healthcare purchaser. We do Medicaid, which is about 1.8, 1.9 million people. We cover public employees and retirees, which is about 370,000 people. And right now we are in open enrollment. It's very exciting. We are going to start covering teachers in Washington State and retirees, which is about another 156,000 people. And we try as best we can to have one HCA and align our coverage policies, our benefits, sort of how we approach things across those very different populations. And one of the goals that we made about 4 years ago was to drive change through incentives, and most explicitly get to 90% of the care that we pay for being in some sort of value-based contract. So I'm taking it up even a level further of like, how do we define value, not just for TAVR, but for everything? And how do we make sure that we are getting sort of the best care that improves health the most for the best price? So some of our guiding principles for that, again, these were, we brought those up and we've tweaked them only very slightly over the last 4 or 5 years. So first, continually strive for the quadruple aim. So lower costs, better outcome, better consumer experience, and better provider experience. How do we make things easier for the clinicians that deliver care to the people we cover? Second, reward the delivery of person and family-centered high-value care, and I'll share with you a couple of examples of how we are trying to do that. Third, reward improved performance across all of our health plans and their contracted health systems, so better quality. Fourth, align the payment and delivery form approaches with other purchasers and payers where feasible. And I think this is really super important because for a clinician making a decision for a person, it's very hard if every different plan has slightly different coverage criteria, slightly different things that they measure, that sort of thing. And so as in the last year, we've brought together a multi-payer collaborative. This has been done in other places. And I'm hopeful that that will really help drive change at the point of care by having that alignment. Fifth, drive standardization and care transformation based on evidence. And then, of course, because this is your taxpayer dollar money, make sure that there's long-term financial sustainability for what we do. So the first example I want to talk about in terms of how do we define value and how do we use that, we have a Washington Health Technology Assessment Program. This started from legislation in 2006, and it is a very transparent public process to pay for what works. It's not that hard. We thought we shouldn't pay for things that either don't improve health, they're not safe, they're not proven to work, and so we have this public process that we go through that comes up with a contractor doing a very comprehensive evidence report, a clinician panel that reviews that, people come and give public comment throughout the process, and then a decision based on that in an open public meeting, looking at safety, efficacy, effectiveness, and cost effectiveness. Spoiler alert, there's very little cost effectiveness on most of the things that we look at. But it is all deliberated in an open public meeting with then a decision made by this committee to either cover the new technology, or in some cases the oldish technology, not cover it, or what's the most common outcome, cover it with conditions. So for certain types of people in certain circumstances based on the evidence. The second thing I'd like to highlight is something I thought you all might be particularly interested in, is that Washington State has really made some great strides and put a priority on shared decision-making. And this started in the early 2000s. Jack Wenberg came and spoke to our legislature and our governor about variation in care, and the result was legislation that we should do shared decision-making. And we should certify aides and have people tell us their values to help drive their care, with the idea that that would decrease variation and people would get the right care. So over the last 2 or 3 years, we have been certifying patient decision aids. These are the 5 categories we've done so far. It is a little bit of a labor of love in terms of we're not really funded for this, but we think it's very important, and I think the process really improves some of these decision aids. We provide some training and support to providers. We put it in our contracts as required for a number of different types of care. And also there's a bit in it for the clinician if you use a shared decision-making tool, and then there's a bad outcome, you're protected some from malpractice claims. So there's sort of a number of different ways that we're trying to promote this. This spring, we're going to have a conference about how do we do this more, how do we spread this, but it's really a cool thing. So what is value? From the payer perspective, and I guess my perspective in general, it really starts with the evidence. So what's the evidence in terms of benefits and harms? And I think TAVR is a really nice example of how that evidence evolves over time. And I think as a payer, it's our responsibility to also evolve those coverage policies over time as more and more evidence is out there. Second, and we really take this quite seriously at HCA, is looking at the patient and family outcomes. So what is their experience of care? How do we make sure we maximize their health, both physical health and behavioral health, and really think about function, sort of what is it that people want to do with their life, and how can we make sure that they keep doing that? Third is looking at quality of care, and there's sort of usual metrics in terms of HEDIS and QF, things that are blessed, although for the most part, the things that we really care about are not things for which there are good metrics. And so we've also put in place, as we move on our value-based purchasing strategy, we've put a number of bundles in place, and we've put warranties in place so that the health system or the clinician that is doing a procedure, if there's a post-operative infection, they're responsible for covering that within a certain amount of time. If there are other complications, sort of they're responsible for covering some of those sort of unexpected need for long-term rehab, things like that, based on a hip or knee replacement. They're responsible for doing that. And so we're trying to drive value sort of through that way. And then last, but certainly not least, is best price. So everything that we do, everything that we cover, we have a $10 billion budget a year, has an impact. And things that are funded in our part of the state budget are things that are not funded in terms of transportation, education, corrections, things like that. And so it is on us to think very carefully, particularly about new high-cost things. Does this really have value for the population or not? And it really, I think, sort of comes down to 2 different kinds of decisions that you have to sort of weight, and there is some uncertainty. On one hand, the sort of policy decision, do we cover something? Do we think it should be covered? Is it safe, effective? That sort of thing. And then the personal decision of, should I get this treatment? Which one is the right one for me? And that is often a balance and can be difficult to do. So with that, I will pass it over to Valerie.
Thank you so much. Well, such a terrific range of experiences and such a an interesting approach from all these different perspectives. Very, very helpful. So to summarize and try to integrate all of this, when I was originally asked to give this talk, I thought about all the different definitions of value that we get taught, and they're all called value. So there's valuation in the sense that many of you use it, from economics, decision neuroscience, decision psychology, and that has the usual expected value, utility, cost-benefit analysis sort of thing. Then there's values the way it's talked about in social psychology and developmental psychology, and in terms of social norms, moral principles, what's valued by an individual, such as a patient, but also a provider, a payer, or a system administrator. Now, you can relate these two to each other. They're supposed to be related in theory. You can, for example, take moral values and plug them into a utility function. But sometimes there's something lost in that translation, and I'm going to talk about that. It's not so simple to define one in terms of the other. Although economists, it all can be utility, right? So as was so eloquently stated here in earlier sessions as well as in this one, the individual versus the population perspective can differ. And the question is, should the individual perspective be reduced to the population perspective or vice versa? And this is the tremendous tension that all of you, I think, are familiar with. Should moral values be traded off? Now, we've talked about trade-offs that involve moral values, so I don't know the answers to all the questions I'm going to ask you today, but I think that they're questions we all have to contemplate. Very briefly, the theoretical framework that my colleagues and I have developed say there's really more than one way to think about these decisions, and that an individual person thinks about it in multiple ways. On the one hand, very typically, people think about decision-making in terms of the gist, which is a bottom line categorical, lives are saved or lost, live, die, that sort of thing, versus a kind of trading off of probability and outcomes of the classical expected utility approach, or even expected value, there's evidence. And people seem to do both of those things, and the degree to which they think in terms of this bottom line qualitative gist influences whether they in fact retrieve their values and apply them to their decisions. So you can separate the application psychologically of social and moral values from the way we think, whether we trade off or not. So I think that provides some purchase on this problem. And today, the speakers here really ranged and expressed the gamut of ways of thinking about the individual decision maker all the way to the societal level. And I think we have to address all of these levels, and that's sort of the bottom line message of my talk. Rather than reduce it to one perspective or another, in fact, I think we have the very hard and challenging task to not disregard any of these perspectives. So what do I mean by trading off? Well, earlier there was a question about saving the individual baby in the NICU versus giving everyone vaccinations. And that is seen as a trade-off between the individual and perhaps a core moral value versus the population. Now, the public, of course, worries about us doing things like that. They worry about us, death panels and quality, and who's going to get thrown out of the lifeboat to save the rest of the people that are in the lifeboat. That's the stark reality of some of the public discourse on this. And public trust is an important intangible in all of this. If we lose the public trust for what we think are very rational reasons, in fact, humane motivations sometimes, that's a problem. So we know from literature, not just based on fuzzy trace theory, but other research, that equity is a core value, though. Treating everybody the same, which is implicit in standardizing care. The core value that motivates that is everybody gets treated the same way, same problem, same treatment. Implicit in presenting a distribution of spending. Did we spend the same on everybody? Is this core value? There's a notion, a kind of implicit assumption there that everyone should have the same expenditure. But think about that. We also have competing values that we also consider core, like suppose you have a dread disease and the only possibility of non-negligible possibility of life is an experimental treatment. There's people in this room, by the way, who are faced with that decision, and some of them are our great decision scientists. And they're alive today because they made the decision for the possibility as opposed to the probability of life. So that's a very distinct value, and yet that's also represented in the brain. So when you think about what's more advanced, we think of, and just about every cognitive theory has assumed that the trading off part is more advanced. The deliberative probability times outcomes, that kind of thinking is more advanced. But there's actually evidence to show that as you get older, from childhood to adulthood, you engage in less of that trading off and more of that qualitative, categorical, gist-based thinking. So there's studies, for example, on framing effects, that little kids are objective and rational and trade off, and as you get older, framing effects actually emerge. And this is where you treat gains and losses differently, even when they're the same. People who trade off seem to have poorer health outcomes, and I'm talking about like personal risky choices. So if you measure their decision-making in the lab and then you ask them, well, how often do you drive too fast or drink too much or have unprotected sex, they're more likely to do those things if they're actually trading off risk and reward than if they're thinking in a categorical way. So if you think to yourself, it only takes once to get HIV, you're less likely to get HIV, at least by self-report. So physicians, by the way, we studied physician decision-making, and as you go from a medical student to a generalist, to a specialist, to a subspecialist, for example, in cardiology, you're more and more likely to make triage decisions, for example, in the ER, based on simple, just categorical distinctions as opposed to trading off. And so in other words, as physicians become more expert, they trade off less and less. So these are all counterintuitive. These suggest that perhaps verbatim trading off is not obviously the most advanced, cognitively superior way to think. Because if little kids are doing more of it and you're doing less of it as you get older, perhaps it's because something else is smarter. But I want to add, though, given all the subtle remarks that were made here, that trade-offs are real. They're not necessarily inevitable, but they're real. So choices like an ineffective, expensive crisis or medical procedures or cheap, cost-effective preventive measures like the NICU and the vaccine example, or like many of the examples discussed here, those are real dilemmas. But once again, to tie this back to Paul Slovik's talk this morning, there's studies on things like the singularity effect, that effect that he talked about where you donate more to the individual one person or the one child as opposed to a group of children that includes that same child. That too increases developmentally. When you're a little kid, you're less likely to share in general. You do get less selfish, but you give more to more children than to fewer. You're rational in that sense, in that kind of allocation sense that we've all been talking about. As you get older, you show the singularity effect where you give more to the one child than to the many. And that really should give us pause to think about, why is that? And what could there be value in that perspective? So, Paul, you've inspired me so many times in my work. And I would say that, one of the implications of the curves he showed was perhaps we should be more linear with respect to the lives. Maybe, we should feel worse when more people are dying, and perhaps that's true. But maybe we should, in fact, think about the difference between nobody and somebody dying, the life of each individual, as the life of the many. So perhaps we're too linear as opposed to not linear enough. I think TAVR is a wonderful example of trying to change trade-offs rather than accept them. So we could say, we looked at the outcomes based on the wonderful work that was shown us of patients who would have surgery or medication, and there was a dramatic difference. So many more people died with just medication as opposed to surgery, but they couldn't have the surgery. So we can think about trading off and selection of patients and all of that. Or we can innovate and develop something like TAVR where we can square the circle, where we don't have to accept the trade-offs because we're going to change the reality rather than accept it. And I think there's always hope of that. So the question is, when do we trade off? And when do we resist the trade-offs? And when do we have the wisdom to know the difference? And in particular, just to close, I think valuing people's preferences, which was pointed out that several people have the responsibility of doing here, to think about what people's preferences are, even when they are irrational based on our classical theories. But this has implications for ongoing trust, because if we say we value the patient's perspective, and then they say, well, except when it agrees with what we would want people to do, that's really not valuing the patient's perspective. So I would say, invite you to think about whether we see human lives from a population perspective as grains of sand, small, numerous, and indistinguishable, Or perhaps we can see in each individual the universe in a grain of sand. With apologies to William Blake.
Thank you all very much. You know, when you put these panels together, you really hope everything comes off great, and I'm just so relieved right now after having heard such excellent talks. So thank you all so much. So now we'll move on to discussion. A few questions to start the discussion, and then people can come up to the mics, and I'll sort of proctor this discussion. But I'll start with the question to the panel. What were thoughts you had while you listened to other people's perspectives? And I won't pick on anybody. I'll let you.
I'll start. So I was really impressed by the role of innovation, and we think about that as a way of softening the boundaries between what seem like hard trade-offs. And it's certainly something that at OHSU we spend a lot of effort on. It is a complicated, expensive, messy process. Developing good data takes a long time. New techniques often don't work great, you know, at the beginning of their development. So one has to think about that in a really long time, societal time horizon. But I think it is a very valuable way of blurring the lines between what look like stark trade-offs.
You know, for me as a clinician, it's just enlightening. You like to think you have the bigger picture, the holistic picture from different perspectives, and it just makes it's striking in hearing everybody speak today on how little of a perspective we have in spite of an attempt to have that perspective. I'll be honest, clinicians today work in largely a vacuum where the decision is this patient sitting in front of me has aortic stenosis, and so the big question is what treatment I offer them rather than whether any treatment should be offered at all. That question doesn't often even enter into the clinician's mind, and it's just a matter of which procedure to use. And frankly, they don't usually acknowledge or interact with the payer. They're not representing often the delivery system about choices of the cost of those procedures. So I'd like to think of myself as a perspective of value that's much broader than I do. It's just been, I guess, sobering to realize sometimes how little of a perspective you have. And I think it really reinforces that it takes a village, the patient voice, and different people. And I would say probably more than any other voice that I interact with, it's the administrative voice of the hospital. But it's often an us versus them tension that exists when it's interacting with payers or other groups as well.
I guess I'll say, and I've done this in other bits before, but I think hearing each of us speak, it's just so important that you take into account all those different perspectives when you're making decisions. And actually, just before this, I was talking about a meeting that we had on Friday that has a number of different stakeholders, actually 4 patient representatives, which is super cool. I think 4 pharmacists, 4 managed healthcare plans, but talking about how do we cover these new expensive drugs that are coming out, and that is going to totally bust the state budget, but had some amazing conversations, and I think this was really good conversation too, from each perspective, there are different things that are important, and so how do we come up with something about coverage, about how we pay for this as a society, what do we do, that I think is really important not to lose sight of, so.
And how do we perhaps, the oversight itself actually costs money, right? So we're in the effort to, and I was thinking about this with all of the talks, to make the decisions you're talking about requires oversight, and it's sort of hard to pull back on oversight, and yet oversight is very expensive. You know, we're monitoring people down to when somebody goes in somebody's room, a timer goes off, and it clicks off when they come out, so we can say how many minutes was spent with each patient. And that this creates an enormous resource-consumptive bureaucaucy. And maybe we can take some of that away and do some of these innovations, I don't know. But I was struck too with some of the things that you said, and again, this is another question to which I do not know the answer. should you wall off clinicians from these concerns of trading off? Is it a conflict of interest to be worried about whether to give something to a patient as opposed to which thing to give to them? Or is that perhaps the clinician is the best person to wrestle with that, with the patient right in front of them? So I don't know the answer to that, but I'd love to know what you think.
I will say frequently we're asked to be the advocate for the patient. Now, the challenge is how you actually remove your own biases or tendencies overall. But ultimately, I think we are asked to sort of understand from the patient perspective. And then frankly, if it's at odds with decision-making, to advocate, whether it be going to a payer, to an administrator and saying, this is really fundamentally the right thing. I fear too often, and I'm trying to keep my clinician hat on, that we inject our own biases and tendencies and use that to shape what is really not true shared decision-making, and I'm not going so far as paternalism, but I think we often, to the point that was brought up, education aside, you could go to 10 different clinicians and get a slightly, or in some cases, a strikingly different view on what is the right thing, even though economically, in terms of everything, it may have the same value. It's shaped by who you talk to, and is that good or bad? And I don't know the answer to that.
So, again, if you have questions, come on up to the mic while people are coming up. Did anything surprise you listening to other perspectives? Did anything surprise you? I'm just curious if anybody has in the panel. Were you surprised by anything?
So I was surprised by this sort of thought that you use sort of more of your gut as you get older than looking at data. And while I'm surprised by that, I think I shouldn't be, because when I'm a general internist, but practice very little in my current role. And I always think I'm doing the best job. And I think some of that is that just like, of course I'm fantastic. There's a number of times that I've shown physicians their performance compared to everyone else, where they are quite sure they are not an outlier. And then they say, oh, I guess I do more C-sections than my colleagues, but they are quite sure that they only do the medically necessary ones. And I think that that is really a tough sort of sense of being faced sort of with data and what you think the right thing is and how you are an advocate for doing the right thing for the patient that's in front of you, and is super hard to untie.
Just to briefly clarify, I should say too that the fuzzy trace theory GIST distinction isn't exactly like dual process. So it is actually based on data. So if you're a real expert and you look at data, you get an essence, and you know, like how sometimes trainees will want to list out every little, it's a list, not a gist. Whereas if you had experience, you can look at all those data and you say, well, what the bottom line is, right? So it's intuitive, it's not always conscious, it's certainly not, you know, classically logical or anything like that, but it doesn't mean it's not based on data.
Great. Michael Berry from Boston. What a great panel and a great morning, actually, going back to Dr. Slovik's talk, and the temptation to link them together is, I'll speak to. So my concern is the extension to people who don't have other options, and we tend to do that a lot with new technologies that seem less invasive. We then push them out to people for whom it's pretty invasive for. So thinking of the geriatric patients with multiple comorbidities, we just sort of play this game of saying, how much is the aortic stenosis responsible for their overall condition? And if I fix that, will they get better? Confessing the proximity bias, I have a recent patient with this who had really tight aortic valve, left ventricle was decompensating, congestive heart failure, so the 2-year life expectancy, but also with chronic kidney disease and diabetes and spinal stenosis and bladder outlet obstruction. But it really seemed like he was tired and short of breath, and that was the dominant thing interfering with his function. His fast thinking was, I don't like invasive stuff. This doesn't make sense to me. We, and I should say I, a fair amount as a shared decision-making aficionado, sort of pushed him toward the slow thinking. Wait a minute, you know, think about whether we could make this part better and how much it'd be overall. And ultimately, he opted for the procedure, a great success from the perspective of our cardiology colleagues looking at his echo, but all his comorbidities got worse. He's been incontinent since then. He had a catheter put in. And he's really convinced it was the wrong decision. And the fact that we probably made him live longer just made it even worse. And maybe that's an exception, but as we again push the envelope to the multiple comorbidities and have to play this game of kind of guessing what we can make better and what we can't, I worry about that challenge and whether we sometimes push the envelope too far and whether the pushing toward the slow thinking is always a good idea. It's just thoughts.
And I would say, just to echo the point that you brought up, is I don't want to speak for all clinicians, but I think in these more specialized areas, we have a very finite defined period. I mean, it's a really embarrassment in cardiovascular medicine where the success of yes or no of how they did is a 30-day timeline for open heart surgery. For stenting today in the hospital, it's did you leave the hospital alive or not? And I would hope that our patients have an expectation of success is measured beyond just was I alive or not when I left the hospital. I think to the point of that is we look at this as very much, here is a problem, I have a solution, and you're thinking in a vacuum very much, I don't want to say oblivious to all the other issues, but you often will inflate the issue at hand. It feeds the narrative of, I think their aortic stenosis is the big issue. And I'm sure as a geriatrician, you deal with this all the time of you're sort of the referee and the ultimate, maybe referee is the wrong word, the advocate for the patient because you may have varied views about what is quote unquote best.
I guess I'll say that our health technology assessment group sort of struggles with this all the time, and that cover with conditions and what are the conditions. And often there's certainly a bias, for example, of like, well, if it's a kid, we for sure want to do it. And if it's not, then maybe not. But how do you know what's the right set of comorbidities? And it often does, even though in design, this HTA process was supposed to make it all very black and white. There is still a lot of gray in the middle in making those decisions. So,
I think maybe combining the last two sets of comments, when I took statistics many years ago, and I wasn't particularly good at it, the thing we were searching for was an unbiased estimator, an estimator that didn't got to the mean. And what I've learned, decades later, is that all estimates are biased, right? And all information is imperfect, and everyone's seeing part of the story from their own, like the parable of the elephant. And that, from my perspective, what that should drive us to do is to add more perspectives to the problem, rather than try to isolate the perspectives under the sense that I'm gonna introduce a new bias. Well, their bias is already there, and maybe the best thing we can do is just bring the richest set of biased estimators to the problem.
Thank you all for a really outstanding panel and discussion. I'll apologize because I was running late to the session, so if you answered this at the beginning, let me know. But it's probably not. I was interested in, from the payer perspective, serving on a committee with the National Academies right now, looking at an issue that has brought this a set of concerns to the table with regards to this notion of what we value as a society. And on the one hand, we have sort of autonomy, kind of very much kind of at play. And there's a conversation that's happening about whether you can really talk about autonomy and choice and informed decision-making in the absence of access. And for our context here in the States, oftentimes that then is about coverage and insurance. And so I was thinking about that as you were putting sort of that value calculation or sort of the approach to thinking about it. And really, it struck me that I'm not sure from a public payer perspective, if autonomy is really a value that is should be a primary driver or be operating, but then at the same time, I think that justice is, right? So if we're gonna look at these pillars and around ethics and values, and so you could also talk about access with regards to sort of justice and equity. So I was just wondering if those are sort of my thoughts that are spinning right now and trying to make some sense of taking on that payer's perspective and what we do feel as sort of our obligations to sort of the individual and their efforts to make informed choices. I see that you guys are doing this work around shared decision-making, but how that does sometimes sort of sit, or feel at least, at odds sometimes with these larger questions about how you can operate, how you can choose in the absence of coverage and access.
Yeah, that is a great question and plenty of spinning. In fact, I was having a conversation last night. Access in Washington to primary care is quite different than it is in Colorado. And so, does that drive people then to the ER? Does that drive people to choose different kinds of care or not get care because they don't have access to a good provider? And so I think access is a sort of underlying, like, if you don't have access, how can you get care in the first place, and should be sort of the first thing. But then I do think autonomy is of value, and having worked in state Medicaid programs for 11-ish years now, I'm always struck by sort of the assumptions that people make about the Medicaid population. They don't work, they hang out all day, when the truth is probably about 75% of the Medicaid population works. And so it's not just, whose life is valuable. For sure, these are very hardworking people that are trying to do their best for their kids and their families and that sort of thing. And so I think autonomy is important, justice is important. And yet there is this sort of tension. We don't have all the money in the world. We can't make money. And healthcare is increasingly expensive for sort of a variety of reasons, although one for sure is that it's a business and people expect to make a profit. And that's sort of how it's set up, and that's the world. And that would be very hard to change to a different world. You could have that value conversation somewhere else. I won't get into it. But I think it is very hard. I'd say Oregon has done some of the first work in this, and being a native Oregonian, I can say that with the Oregon Health Plan, of sort of what are the right things to pay for, and we have to make choices, we have to make trade-offs, whether we like it or not. And there will always be someone that doesn't get something, and how do we try and make that be sort of the best case? There are for sure, and again, the conversation last night, sometimes when you don't get healthcare, you get better, and you don't need healthcare, and you think you need healthcare, but actually maybe it's okay. And so, but it's really hard to figure out where are those cases where maybe you didn't need healthcare, maybe you didn't need the TAVR because your life was going to be not so good with it. But that's really, really hard to say. And, in decision making, a lot of people value, disabilities less. I can't ever imagine myself without an arm, and then you don't have an arm and you're like, oh, I'm fine. And so it's really hard to sort of figure that out, and how we make, if we don't make, I guess I'm a believer, if we don't make choices consciously, we're making them unconsciously. And that's a problem. And so I think in my work, I really try to get a number of stakeholder views in the mix to try and make those choices a little bit more explicit to get to sort of good ethical principles. It doesn't always work.
Thank you. Thanks so much. Just a quick note on this. We do think about pitting these two against each other, of autonomy and justice. And I would say, let's not do that. I think that's a false dichotomy. I think what you're talking about is a question of communication. So if we can communicate better with patients about end of life, about expensive treatments, that in fact, with their full autonomy, if they were fully informed, they would not choose to do, I would rather go there. And I think we have to always be aware, when we give away the autonomy of people, which people are more likely to have their autonomy given away? It's the outgroup, it's the minorities, it's people who are poor. So we have to be very careful about these two values being traded off against one another.
Agreed, thanks.
So we have 40 seconds left. Last question from Dr. Wong.
John Wong, Boston. Lovely symposium. I wanted to go back to the patient perspective. Thanks so much for sharing yours, Susan. One of the things that you had to grapple with was the uncertainty of a TAVR as a relatively newly developed technology. And that's pretty common across all of these new expensive technologies. There's an uncertainty involved in that. How did you grapple with that? I recognize that for you, an open heart procedure carried additional risks. But how do you think about, in terms of shared decision-making with a patient, how best to convey that long-term uncertainty, which applies not just to TAVR, but to a number of other conditions too?
Right, that's a great question. The first thing that comes to my mind is a person's risk affinity. I mean, it's almost like investing. You know, for investing, you look at a person's risk tolerance, and I think that's part of it. For me personally, I knew 3 people the year that I had TAVR who died from open heart procedures, and so that was more pressing to me personally. So I really didn't look at risk very much at all. I mean, TAVR just seemed very intuitively to be the right thing for me, so I didn't spend a lot of time weighing and processing. It was kind of me personally, death versus the TAVR, and so it was not something I grappled with. Other patients I meet tend to be much more wanting to look and study and that sort of thing, and I value that as well, but that wasn't the process for me.
Well, with that, I think that's it. Karen has a couple quick comments, but I will say one thing that always surprises me, we did a panel like this in Colorado, is that no matter what level or your perspective, people are humans first and everybody cares. And that was one of the aha moments for me before and again today. People have different perspectives, but whether you're a payer or a CFO, everybody still cares about doing the right thing. And so anyway, thank you. So Karen, you want to make a couple quick comments?
I do. I just have a housekeeping. First of all, I want to say thank you to our panel. Wow, this is incredible. I wanted to just let you know about the lunch options. The Multnomah Grill has a hot